Thank you, everybody. Hello. It's lovely to be back in London. What Paddy neglected to say was that I was a so-called supervisor of his PhD and taught him everything he knows. So there we go. And my husband Ross and I are over here ostensibly for this cannabis conference that's on over at Canary Wharf, which is extremely interesting in some ways. And I thought it would be good to take this opportunity to spread the word about some of the trials we're doing for medicinal cannabis, which is necessary as part of our program as one of the. So, pot or panacea. Now, this isn't going forward or back. There it goes. Yeah. Okay. So in Australia, there has been enormous interest in medicinal cannabis among the general public, and with cures, multiple beliefs in the benefits of cannabis and what it can do, and multiple claims of benefit. You just look at Google, this is what it says that CBD can do, including that distressingly treatment of cancer. So following that robust public pressure, the Australian government legalised medicinal cannabis in 2016. And on the basis of pharmacoepidemiological data, they legalised it for use in epilepsy, nausea and vomiting, chronic pain, spasticity in multiple sclerosis, insomnia and palliation, whatever that means. Okay. Yeah, okay. So that legalization, however, was not accompanied by any requirement for monitoring of efficacy or adverse events. So since that time, there has been an absolute explosion of prescriptions for medicinal cannabis. One gets the impression after listening this morning that per capita, the number of prescriptions per capita is much, much higher than it is in the UK. Large number of people take it illegally, they're using street cannabis, but there has been an absolute exponential rise in the prescription of medicinal cannabis. And over the years, the government has made it easier and easier to prescribe cannabis. The system sounds very different from here. There are two main prescribing pathways. One is via a thing called the Special Access Scheme, where if you have a particular patient, an individual patient with a problem, and you can show some benefit of that problem, you send it off and you get permission to prescribe pretty quickly. The other way is called authority prescribing, which is group prescribing, where you have a group of patients like palliative care patients or patients with epilepsy, or in our case, patients post-trial, and you can get permission for authority prescribing for that group, which is what we do for post-trial patients. So the majority of those prescriptions, and this is quite consistent what we heard today, pain, anxiety, and sleep disorders. And PTSD is quite big too, with very small numbers of prescriptions for other indications. This in turn has led to a multi-billion-dollar business. This is an old slide showing our market capitalization nationalisation of a number of cannabis companies. A number of those have fallen by the wayside, but others have grown. And so this is a huge business. But it's all, as you can imagine, backwards forwards. Usually when you have a new drug that comes onto the scene, it's gone through a whole range of preclinical and in vitro tests. People know the correct dose, they know the indications before it's launched onto the market. This has all been backwards and forwards in Australia, and that it's been launched onto the market with very little evidence to tell you what to do. And there are so many, what's the best product or combination, what's the best route, schedule, very little PK data, a lot of talk about drug interactions, but not a lot of hard interest or evidence. Which are the best symptoms to target, etc. And as I say, there has been no requirement for the reporting of adverse events to date. I'm sure everybody is familiar with, well, maybe you're familiar with the two major components of cannabis, the cannabis plant, which are THC, and very hard to say, which is meant to have psychoactive appetite stimulant. You can read there all the purported benefits of THC. And the other major component is CBD, which is an S4 drug. I don't know, you won't have the same here, but S8 drugs are the control drugs, the opioids, etc. An S4 drug is one that can be prescribed, doesn't have to be locked up or controlled in any way. And that's cannabidiol, and it's meant to have anti-inflammatory, anti-epileptic, antipsychotic, etc. properties. The problem is, within the cannabis plant, there are up to 400 different cannabinoid compounds and a whole lot of other compounds, flavonoids and terpenoids. And it was very interesting today at the conference, a lot of talk about terpenes and a lot of discussion about the need to have the whole plant and the terpenes to get the benefit. Okay. Is that better? Is someone here now? Can someone unmute?
I think the issue is that you keep coming and going.
Oh, I see. Okay.
You're quite strong, and then it's almost like you're turning your head away from the microphone, and we lose you.
Okay.
So I don't know where the microphone is, but it's whether or not it's possible just to have it.
Sure. I'll just.
So right now we can hear you.
Okay, I'll just keep it here. I'll keep it here.
Brilliant. Thank you ever so much.
Okay. No. All cool. Okay, so there we go. One of the main problems with THC, and no one seems to be particularly worried about it at the conference, is that THC affects your driving ability, and therefore it is illegal to drive on THC in Australia. And the government are pretty hot on that, even if it's used for medicinal use. I don't know what the situation is here. I presume it's a drug, an S8 drug. I don't know, but right, yes. I mean, I know at least in New South Wales, if you get caught with THC on your system, fine and automatic license. And so as we'll talk about, this has been quite a strong factor in the running of our trials. But it is also extremely complicated. If anyone's interested, we'll talk about it later. You measure, because that gets all complicated as well. So in Australia, there are a number of products that have been approved. You're not allowed to advertise them, but a number of products that have been approved and can be prescribed. There is also cultivation in Australia. There's a very strict cultivation program. Plants have to be stable over a number of years, and they have to be consistent in their percentage components, etc. And nowadays they're all categorized as here as to whether they're CBD dominant or THC dominant or balanced. And so every product has to be categorized in that way. Okay, so there are only a couple of drugs that are actually registered products in Australia. One is Sativex, which is for MS spasticity, Nabixmol, which is a 1-to-1 THC CBD, and the other one is this drug which has been approved for the treatment of resistant epilepsy in those very rare pediatric syndromes of resistant childhood epilepsy. We don't have nabilone in Australia. I think you still do here. People use nabilone. I remember years ago, nausea and vomiting. And dronabinol, that's another synthetic THC. It's certainly not in Australia. So they're the only absolutely approved, TGA approved products, i.e. subsidized products. All the other approved products are approved prescription, but it's all private prescription. So patients pay, and the price per bottle varies, but it's between about $200 and $400, 50 ml bottle. So it's quite expensive, and I think that's the same here. Chap this morning was saying it costs someone $1,000 a month. Something like that. So it's really quite expensive to an ongoing course of medicinal cannabis. You can't just stick a label on any old plant and call it medicinal cannabis. It has to be an approved product, but there's a lot of ignorance around that. And for instance, our son-in-law, policeman, and he said if he saw that lying on someone's seat, he would just ignore it. So a lot of people try and I think get around the system by saying they're cannabis use. Okay, so what is the evidence to date? And we went back and tried to find out exactly what there is. They've got quite a few slides here, so I'll just whip through them. As I said, these are the approved indications in Australia. So the evidence behind them is such, as I say, there is some evidence, you might call it mild or moderate quality evidence for the pain and spasticity associated with MS. Epilepsy, there is good placebo-controlled, randomized controlled trial of CBD alone for these rare pediatric epilepsy syndromes we're talking about. So that's really the only area where there is strong evidence, but very rare. Nausea and vomiting, I've done a lot of those studies over the years. These are the original nausea and vomiting studies. You can see that cannabis does quite well against placebo, but when you test it against standard anti-epileptic medications, the effect is less clear. And if you look at the dates, these are all very old studies before the modern antiemetics, the 5-HT3s, etc., came along. The one promising thing is this was a study that was done in Sydney. This is a 1-to-1 CBD THC combination that was used for the treatment of chemotherapy-induced nausea and vomiting. This was phase 2 crossover study, and the results of that strong enough that they have now gone on to do a proper randomized control against 5-HT3s. They're having trouble recruiting, I understand, because of the driving issue. Obviously, a lot of patients having chemotherapy drive, and you can't prescribe it to drive. What about pain? Well, there are so many reviews out there on cannabis and pain. As my colleague says, there are probably more systematic reviews than there are trials. And the trouble is that a lot of them are of relatively poor quality, and what they're doing is lumping together a whole lot of heterogeneous trials and products and endpoints. So it's very difficult to come to any sort of firm conclusion. The Cochrane reviews are obviously the best, and the industry sponsors tend to be the less strong. And the ones that include uncontrolled studies tend to be the ones that are wrong. And this is the sort of thing that happens, and this is why you can understand the general population believes that cannabis is so effective. This, I just put this up as an example. This was a very good trial looking at some pharmacokinetics of cannabis. And that was the main point of doing it. But as a sort of afterthought, they looked at the pain and quality of life and the other symptom measures on the patients. There were only a very few number of patients, about 25, I think. It was completely open, controlled, but, you know, the claims of the benefits. And this is what patients see. This is... oh yes, this is very interesting. This is a very good paper. I would strongly recommend this paper. This is all about looking at the placebo response in randomized controls of medicinal cannabis. And the conclusion of that review is that in all of these trials, there was a significant pain improvement in response to placebo, with moderate to large effect sizes, and that there was definite publication bias when it comes to reporting the benefit of these trials, and very few people mention the extremely high placebo response rate to cannabis. And I think this is so important, and why it is therefore so necessary to do randomized controlled trials. Pain, as I say, lots and lots of meta-analyses. You won't be able to read this, but most of the forest plots look like that. This is, I think this is numerical rating scales, you know, a few studies are to one side of the line. Like that bottom one there, Ross, is the acute pain study that the guy presented today. But most of them really do not suggest that cannabis has any major benefit with pain. And that has led to the major pain groups really concluding that they can't recommend medicinal cannabis. They can't say whether to recommend it or not, because the quality of the trials is so poor. And this is pretty consistent with major pain groups. They're really sitting on the fence and saying that more research is necessary, and that medicinal cannabis can really not be recommended at this stage. This is one area where I thought that medicinal cannabis may have a role in chronic non-malignant pain and chronic primary pain, which includes conditions like fibromyalgia, chronic pain syndromes, irritable bowel, migraine, etc. The sort of pain conditions where you expect there to be a large emotional overlay. And even in that area, there was very limited benefit to placebo, except perhaps for fibromyalgia in the longer term. This is the most recent review. I just add these reviews as they come along. This one was just published very recently. This is a very large meta-analysis of a number of randomized controlled trials. You can see there is, I think this is another point, and I mentioned it this morning, you can have several systematic reviews done published within the space of months, and none of them really suggest that medicinal cannabis is the magic answer to pain and that it's going to replace opioids. You can see some benefit in some of those trials there. This is all pain, chronic cancer pain, non-cancer pain, some suggestion of benefit. However, the effect size was of questionable importance. We would usually say that the clinically significant improvement in pain is 8 or 2 on a rating scale. The benefit here, or 3. So is that really clinically significant? A lot more adverse effects in the cannabis, and the conclusion was benefits. So this is a real dilemma. Patients swear by medicinal cannabis. Several of the doctors this morning have wonderful results, very effective, but it's become increasingly difficult to demonstrate. So, okay, so that's pain. Just very briefly about other symptoms in palliative care. Very little evidence of benefit for any other symptoms. Recent review, you can read there, some benefit in HIV patients for weight gain, but not nausea and vomiting. Similar one in panacea. Disappointingly, quality of life, review of quality of life, showing no improvement. Another quality of life one, and this is the most recent palliative care review. They included uncontrolled trials, and therefore they had positive effects, but very low or low quality of evidence, and no meta-analysis possible because of the heterogeneity. So, Janet and Philip to the rescue. We were very fortunate in 2018. Philip Good is my colleague. You may have heard of him. He's a very active researcher in Brisbane. He and I were successful in a big grant, Future Fund, which is now one of the sources of funding in Australia. We got one of the first grants in that program to run a medicinal cannabis research program. Now, because it's been so difficult to show an improvement in individuals, we elected to look at total symptom burden, which we in all our patients, but we've used it in trial context, and so our primary outcome measure is the total, and that's for the total symptom.
Janet, sorry to interrupt, but you're going in and out again.
Sorry, I'll try and concentrate. Sorry, I'm getting too excited here. So this is the basis of all our studies. And we started off designing a 3-arm study, placebo versus CBD alone versus THC CBD 1-to-1. But as is so often the case in cannabis research, your supply lets you down. We had great fun at the beginning trying to get a supplier. Many of these cannabis companies, they're not pharma companies. They've just developed overnight. They've had no experience in research. As soon as you start mentioning litigation, sponsorship, etc., they run pills. Our favourite one, we were in negotiation with a company in Jamaica, but that fell flat. And but in the end, we had a reliable source of synthetic CBD, pure CBD that was produced in Australia, and subsequently, so we started that trial alone, placebo versus CBD, and subsequently we got a reliable source of THC from a company in Western Australia that grows their cannabis. So we call that Medcan 1 and Medcan 2. Medcan 2 being the 1-to-1 THC CBD. So our primary objective was to see if the oil could improve symptoms of stress in patients receiving palliative care. So all the patients receive standard palliative care. We did it in 5 metropolitan hospitals in South Queensland. And to be eligible for the trial, you had to have advanced cancer and symptoms of stress. You had to have a score of greater than 10, total symptom score out of 90, and one of the symptoms had to be greater than 3. This was patient titrated. We started low, go slow. We started on small doses of cannabis oil or placebo oil that was matched taste, appearance, color, smell. And as I said, the primary outcome was the ESAS, total ESAS score, and we defined response as a greater than 6-point reduction in total symptom score. And we chose that because Hui and the MD Anderson had shown that a palliative service can, palliative care alone can achieve a 6-point in total symptom. The trial was powered around that, and that's what we used as a definition of response, although our primary outcome measure was the fall in ESAS score at day 15. And we looked at all the predictable secondary outcomes, the physical and emotional subscales on ESAS, the individual symptoms, opioid use, et cetera, et cetera. And the first study we have completed, we'll go through the results in a minute, and that's just come out, well, at the end of last year in the JCO, which we're very proud of, and I hope reflects the quality of the study. So there. And the really good thing about this trial was that it recruited so well. This is your dream, Paddy. Oh, you know, under time, under budget, despite COVID, despite everything, still took 3 years, but we managed to get the 144 patients recruited that we needed to achieve our sample size of 120. So that was the calculated sample size. And you remember our primary endpoints were day 14. That's just your standard consort diagram. Obviously, this is palliative care. There was quite a bit of attrition, and you can see those numbers fell quite significantly to day 28, which is the end of the trial. What happens is patients self-titrated, guidance, research guidance until day 14, and then they selected the dose suited them or was tolerated, and then continued that dose for 28 days. This is, I think it's a pretty typical palliative care population, about 60s. They had quite a good performance status, and a mean ESAS score of about in the 30s. Most of them were on opioids, and a lot of them were on concomitant medications. I think the median concomitants per patient was about 11, so elderly patients all on a range of various medications. So we kept all those medications going throughout. And these are the results. Easier to show them pictorially. This is over time. So the total symptom score fell over time in both arms. The green is the CBD and the placebo yellow, and it fell in both arms. At day 14, the total score had fallen by 6 in the placebo arm and by 3 in the non-significantly better in the placebo arm and no difference. And this is the waterfall plot. All the patients under the second red line responded. They had a greater or equal 6-point reduction. That's CBD, and that was about 45, I think, %. Yep, 45, and the placebo 8. Once again, but in favor of placebo, which was very disappointing. Similarly, all the secondary outcomes were completely negative. Don't look at these numbers, but these are just the individual symptom scores and the subsets of ESAS, emotional and physical scores, all got better, you know, in both arms, but as you can see, not a p-value anywhere near significant. This is anxiety, depression, stress score. We were particularly disappointed in this because our pilot study had suggested that there might be a benefit in anxiety. But once again, depression, anxiety, stress scores improved over time, but they improved as much placebo as cannabis arm. Similarly, the quality of life scores improved in everybody, but no difference between them. A lot of people said that we would have to stop people's opioids when we start them on cannabis. This is the change in oral morphine equivalent from baseline. The median change was 0 in those groups, with a huge range. As you can see there, no patient can reduce their baseline opioid dose, although had a reduction in their PRN doses. The median dose was 400 milligrams a day of CBD, which is also interesting because I know Marie Fallon is just about to do a study of medicinal cannabis for peripheral neuropathy, and they've chosen 70 milligrams, well below what we got as the median dose. And remember, this is patient selected dose, so that was tolerated. We've talked about opioids. Similarly, we looked at the patients who were on benzos or antipsychotics, and we looked to see if that affected their dose of CBD, but it didn't. So, as I say, lots of concern literature about drug interactions, but we found no clinical evidence of that using NCB dose as a surrogate measure. I think that just is the same thing. These are the adverse effects. I would say that the CBD was extremely well tolerated. These are the adverse events of special interest. The somnolence almost reached significant, which was encouraging, and seemed to be the main reason why patients reduced their dose. The other one, for some reason, was vomiting in the placebo arm. But once again, of non significance. And for some reason, there was more dyspnea in the CBD arm, but very small numbers. There was an enormous number of adverse events in the study, but remember, these are all patients with cancer on lots and lots of steroids and usually often chemotherapy or immunotherapy. So a huge number of adverse events, but no more in the CBD arm. So that's one thing I can say, and I think valuable thing from this study is that we showed very well tolerated. Survival, still a lot of patients believe that cannabis cures cancer. A difference in survival, but this is obviously just a 28-day study. Global impression of change improved in all patients up to day 21 and then stabilized, but improved as much in the placebo group as it did in the cannabis. That's just clinician assessed compared to patient assessed. So the conclusions of our study, strong public belief in the benefit, multiple reviews, but it's becoming increasingly difficult to demonstrate the medical benefit of cannabis, at least in the randomized control setting. Very popular trial with patients because it isn't THC and doesn't have the psychotropic effects that a lot of people are frightened about, and you can drive. But we showed that it didn't add in any way to this. It's really not against placebo. It's really all patients got palliative care. They all got better, but CBD give you any further benefit than palliative care did. However, CBD is well tolerated with minimal adverse events. So we finished that study and proceeding on to Medcan 2, which is the 1-to-1, the 10-to-10. This study has been more difficult to recruit to because of the whole driving issue. And so we are slightly behind predicted. The major gap there is COVID, and the other major gap up there is a supply issue. Supply issues continue to be a problem. When I left Australia, there were 18 patients to go. So we're very close to complete. And it will be extremely interesting to see if the addition of THC to CBD makes any difference. I'm sure we will be criticised, however, because there are no terpenes in here. Once we've finished Medcan 2, my colleague is proceeding with Medcan 3, which is another CBD dominant product. And we're concentrating on a lot of the issues that were raised in the previous cannabis study that we want to look at further. As you can see them there. We did an inflammation sub-study in Medcan 1, and we haven't published that yet, but fortunately that was dead as a duck with no evidence of inflammation as compared to placebo. We're monitoring all the patients post-trial. About 30% of the patients who have completed trial requested, and we do prescribe for those patients, and we monitor them closely, see what they end up with, what dose they have, what adverse effects they have. I'm very keen on doing some happiness scale. As they mentioned today, many patients, the finger on it, they can't show any improvement, objective improvement in their pain, but they just feel better. As I say, many patients elect to continue. There is this, they used this contentment And, you know, maybe our problem is that we're just not measuring the right things. So we've tried in MedCan 3 to include a measure of happiness or contentment, because it's just incredible the public belief and the belief by many doctors who prescribe it and see improvements, whether that is all the strong placebo effect or whether it's something we're not measuring. So that is what one of the things in MedCan 3. So in summary, at the conference this morning, people were saying it's just not possible to do randomized controlled trials of medicinal cannabis. We would object to that. We would say it's highly feasible, as we've shown, that it's popular with patients, that it's really easy to make things, very hard to tell who's what. Drug interactions haven't been a concern, haven't had to reduce opioids, and it's easier to recruit these patients when you give them an opportunity to at least try them. Completed the trial. The barriers are establishing a reliable supply. As I said, the lack of experience and research in many companies, the driving issue, finding cannabis naive patients. A lot of people out there getting cannabis from the street, and pointingly, a lot of people come along. One of our requirements in the trial, H negative to enter. A lot of people swear they've never touched it. Disappointing, and which reflects. And I think a lot of cancer patients hype around it that they really feel they're letting themselves down if they don't. As in all our trials, quite a bit of attrition post 19 days. I think in all our trials, it's really difficult to do a trial of palliative care that goes on for 2 weeks. So finally, I'd just like to acknowledge our team in Brisbane, sunny Brisbane. And I just put this slide up in the end because I was just interested to know where the audience stood and how what you were doing with in this tree. Seems to be a lot less, I think, perhaps than in Australia, but it also sounds more different. I'm very interested to hear your views. I'm sure, like you, we have every patient who comes for it. Yeah.
Janet, should we go to some questions?
Yes.
Yeah, thank you very much.
Don't know if there are any other.
Okay,
I
lovely.
don't know if there are questions.
Thank you very much. We're going to go to questions. If people online are still there and can hear us, please type your questions into the chat. But otherwise, we'll start in the room.
And as I was saying it, I would say, you know, what.
Would you mind just repeating the question
Okay.
as well, so people
Okay.
online can hear it?
So the question is about standard palliative care. And I think you're saying, how can palliative care be standard? Because there's different settings and different teams and whether that made a difference to the patients. The vast majority of patients that were recruited from the MARTA, which is weakness and a strength in a way, because we're a relatively small service and our practice is pretty consistent. Strongly peer reviewed, so I am pretty confident that everybody in the MARTA had a very similar sort of practice. I can't vouch for the other services, although in Australia, in Brisbane, it's a relatively small community, and I think practice is really relatively standard. We do quote some standards in here that we would, they're American standards, which we would say. Everyone got regular reviews. They were rung every 3 days by the research nurses. We started off seeing patients weekly. Post-COVID, we did video links on day 7 and day 21. So they were very closely followed, which I believe is probably one of the major reasons why so many people improved. That sort of answer your question. But, you know, by definition, because of the method, they were followed very.
We have a question online, David, if you'd like to ask your question.
Yeah, yes, I follow a couple of websites called Nutra Ingredients. They're sort of propaganda for the supplement industry, which, as you know, is worth many billions of dollars a year. And they are crazy to push CBD because they make a lot of money out of it. And it was really interesting to see the meta-analyses. I don't really believe any of them. There were tiny effects and they were inconsistent. They're very modest p-values. And as we know now, p-values are over-optimistic in many cases, most cases. I was also interested to hear that you say that the standard of trials was lower in the industry. In real drug trials, it's actually the other way around. The statistical standards are higher in the industry trials, but this is not the regular industry. As you say, these are a lot of cowboys trying to make money selling stuff that doesn't work.
Not sure I said that, but anyway.
David, well, let's Janet answer. Hang on a moment.
Well, yeah, no, I think it was the reviews that were led by industry that tended to be of poorer quality, often because they included a lot of uncontrolled trials, and so the quality of the evidence was low. But yes, CBD is sold as nutritional supplement in the States, and there was plan for it to be over the counter in Australia, that you could just buy 50 milligram CBD tablets over the counter. But unfortunately, to do that, they had to have evidence. Until recently, there just wasn't the evidence for that. Similarly, a lot of people, I got some pretty vehement emails after this trial was published by people saying, of course, CBD doesn't help pain. Everybody knows that. It's just a nutritional supplement. And fair enough, but it's extremely popular with patients. And there is still there are still lots of benefits purported to be as a direct result of CBD.
Thank you. Ask about terpenes. I missed what you were talking about at the beginning about terpenes, but clearly people were upset that you didn't include them. I wasn't sure what they were.
So in the cannabis plant, there are these 400 cannabinoids, but then there's all this other stuff And I think they're called terpenes, and there's an effect called the entourage effect, which states that if you don't have the stuff in with the cannabis, it doesn't work. And that's why smoking a joint is so effective, because you get everything, you know, you get the, and it's interesting, a lot of, in countries like Israel, a lot of the people are smoking high dose THC. Of course, that brings up the whole issue too of addiction here, and misuse, which is something else which complicates the whole cannabis picture. Flavonoids too. I really must find out what a flavonoid is.
The other thing that was interesting was your comment at the end about maybe you're not measuring the right outcomes, because it made me very much think of Lucy's PhD, who's sitting in the audience here, who's looking at randomized controlled trials of complementary therapies. There is an equally strong feeling among the public that these treatments are effective, but randomized controlled trials don't generally show benefits. And the question is that because they're not effective, or because people aren't measuring the right outcomes? So Lucy's PhD is looking at trying to define the core outcomes that would be relevant for complementary therapies. And I wondered, maybe that's a discussion you two could have after as well.
I think you'll find it's because they don't work.
Okay, that's certainly a view, but let's yeah, we'll have a discussion about that. Maybe that's a topic for another seminar. Hand up in the audience, yeah. Do you mind just quickly repeating it for the online?
Question about the placebo effect and how strong is it? Well, it has been published that in palliative care, the placebo effect can be as high as 70%, but it's more commonly, I think, about 30–40%. And several of the trials that we've done over the years would be without ketamine trials, for instance. The paper I quoted, which is, if you're interested, I'd strongly recommend that you read that, because it's very, very interesting. It's quite complicated text that I'm not sure, but that sort of range of placebo effect, you know, very strong. And that's why I believe it's essential to do these randomized controlled trials. Otherwise, you know, how do you know it's not the placebo effect? But I don't understand about nausea and vomiting. Sorry. Yes. I'll just answer that question. Is that because, don't forget, all those patients were on opioids, antipsychotics, steroids, chemotherapy, so it captures all that. I think that was non-significant. I think it was just by chance. Yeah. Yeah. Yep, and that's you know, an ethical question that a lot of people have posed. How to harness it is difficult. Do you want to answer that?
There was an interesting paper just recently by David Huey, actually, on open label placebo, actually telling people this is a placebo, I'm giving it to you, it's a placebo for fatigue, and it works better than, yeah. So, well, if you tell people it's placebo, you're not, it's not unethical. You're not concealing it. You just say, I'm giving you a placebo, and you know, we know that many people feel better with a placebo, so I'm giving you this placebo in this trial. And yeah.
May I point out?
Clearly more work to be done on that.
May I point out that the placebo effect is not beneficial to patients by and large. It's regression to the mean mainly. It's a change with time which takes place in both groups. But it's, in order to see a genuine placebo effect, you have to compare the placebo with no treatment. And where that's been done, they turn out to be much the same. So the placebo effect is not actually beneficial to patients. It's just an artifact of the passage of time.
So interestingly, in this David Huey paper, they compared placebo with a delayed placebo. So there was a waiting list for the placebo, and they demonstrated that being on the placebo was better than being on the waiting list placebo. I'd have to refresh my memory of the actual paper, but it was quite a clever design to clinical benefits. Anyway, we have another hand up in the audience. Ollie, I'm afraid this will be the last question.
Me?
Market forces and demand that some company has said we've got a whole range of things that as you say, need to go in RCT. I just wondered from the conference today, clearly the UK is behind Australia, what you suggest that we could do in the UK side, because clearly does need people work on. Yeah.
I think they were saying today that the NICE is actually releasing some money to look at. And I agree what you say about the complexity. There's a company in Australia that's trying to do a study on medicinal cannabis in neuropathic bone pain in cancer. Now, we all know how difficult it is to diagnose neuropathic pain. How often is neuropathic pain not mixed? How often is bone nets give you neuropathic pain? I think they're, and also the tools they're using to define neuropathic pain are so stringent. They're never going to get anyone in, but they're not prepared to listen. I think our trials are a relatively simple design, and I think that's why they're so they recruit so well, and they're relatively easy to do. Where are the ways of the future? Well, I say sleep. There's a whole lot of stuff about sleep, and I think if medicinal cannabis has a place going forward, it probably will be in sleep. I thought anxiety, but I don't have the results of MedCan 2 yet, so maybe that will show. But I think that would be a area in palliative care to look at, because it's a relatively non-toxic CBD anyway, if it does affect sleep. Although most people use THC, ironically, for sleep rather than the CBD.
Thank you very much. Thank you very much, everybody who's been listening online. I apologise for the poor sound quality. I hope we can entice you back into the auditorium for future conferences. But thank you very much for listening in. Thank you so much, Janet. It's an amazing trial of your presenting abilities with the number of distractions that were going off in the background. Every second there was a beep, a holler, as everybody came and left and everything else. So well done for managing to keep your concentration going, and thank you so much for coming in. So as you'll be aware that Nikki's disappeared outside to set up a few refreshments. So there's a glass of wine, some soft drinks, a few crisps, etc. If people would like to stay around, have a little chat. Hopefully Janet will be up to having a chat if you would like to speak to her, but also please have an opportunity to network with each other. That's one of the joys of people actually coming to the Congress. So thank you very much for coming, and we'll see you shortly. Where is it? Sorry. There we go.